Hi, this is Laura Kaiser, Advanced Practice Registered Nurse, Wound Care Nurse. Today we're going to talk about pressure injury, also known as pressure ulcer. If you remember in the last presentation, I told you that the NPUAP changed the terminology from pressure ulcer to pressure injury, but the staging has remained the same. So we'll review that. To review the functions of the skin, it provides protection, excretion, absorption, secretion, regulation, and sensation. So the skin is the largest organ of the body, so it's very important, but sometimes it's the most neglected. And that's we find that in the healthcare, skin is not really on the top of the list. So if the patient's in ICU and undergoing life-saving measures, sometimes they develop an ulcer, and it's not always at the top of the list of things to do. So some of the pressure ulcers are unavoidable, but you have to prove that you did everything you could to prevent it, and then the patient got it anyway. And it can get pretty difficult in charting to defend yourself. Anyway, we'll talk about the wound classification. We need to know, is the wound opened or closed? Is it pressure? If it's not pressure, we don't stage it. But do we claim it if it's pressure? And that's where present on admission, POA, or hospital-acquired HA comes in. On the admit assessment, we do the Braden score. It's very important to capture any pressure ulcer that's present, and then we'll talk more about the Braden score at the end of the presentation. Here's Dorothy again. It's very, very confusing, but very important that we do it right. So the number one treatment for pressure injuries is to relieve the pressure, and that kind of is pretty simple, but that's not all it is, but that's one of the most important things that we need to do. If we don't relieve the pressure, then everything else we do is not going to take care of the problem. Here's the basic skin anatomy, where we have the epidermis, the dermis, and the hypodermis, or the subcutaneous layer. The blood vessels are all in there, and the stages of the pressure ulcer, like I said, are not any different. It's just the terminology. The NPUAP is the National Pressure Ulcer Advisory Panel, and they serve as the authoritative voice for improved patient outcomes in pressure ulcer prevention and treatment through public policy, education, and research. The stages are still the same. They're stage 1, stage 2, stage 3, stage 4, unstageable, and deep tissue, and we'll go over each of those. Stage 1 is non-blanchable erythema, and you can see that it just extends kind of into the epidermis, but it doesn't go far down, and it heals without problems usually. If we relieve the pressure and protect the patient and everything else is okay, then that's going to heal and there's not going to be a scar. Stage 2s heal the same way. The difference is the stage 2, usually there's some break in the integrity of the skin. It could be a fluid-filled blister, serous or serous-sanguinous. Bloody blisters are deeper than a stage 2. Stage 1s and stage 2s will heal without scar formation, and they just kind of epithelialize. Stage 3 and stage 4 is a little bit deeper. The stage 3 goes into the subq, but not to the bony prominences or the muscle. So if it goes, it's a break in the skin. Sometimes it can have slough, sometimes not. But it's deeper than a stage 2, and it heals with the scar formation. And your tensile strength with healing is never at 100%. At stage 1 and 2 healing, you are back at 100% if your tissue was good when it started. So that's the difference. Stage 4 is even deeper. That's the one that goes, if it goes to the muscle or bone, then stage 4, and you can't get worse than a stage 4. Then you have the unstageable pressure injuries. The unstageable is when there isn't break in the skin, but you're not real sure how deep it goes, and sometimes it's covered by dark leathery eschar, or sometimes by slough, or both. If you look at the slides, you can tell the damage is actually deeper. It's deeper than a 1 or 2, but you're not real sure how deep it goes until you can visualize the bottom. So you're not going to stage it till you can visualize the bottom. And if there's significant amount of slough and it looks like a 3, then you're still not going to stage it. Now, once you can stage it as a 4, you can clean that slough out, and a 4 is a 4, so you can't get deeper than a 4. Tissue damage can be worse. But real important, on admit, if your patient has an unstageable pressure injury, very important to try to get that wound debrided so that you can at least stage it. And we'll talk more about that. Then we have the deep tissue injury, deep tissue pressure injury, and that's where you have the big bruise. And in certain skin tones, it's kind of, just looking at it, it might look like a 2. I mean, it might look like a 1. But when you feel it, it's a different feel. It's like a mushy, kind of firm, just a different feel. You kind of know the patient's history and know. If you're not real sure, then describe what you see. If you have the deep, dark purple bruising area, describe it. It's better to describe it and call it a deep tissue injury than to call it a stage 1 and you end up with pressure down to the bone. This slide shows you areas that are prone to increased pressure, to pressure ulcers on a person. The bony prominences are more at risk. The scale on the left side is pressure related to the diabetic foot or the neuropathic foot. We talked about nutrition in the treatment of wound healing, and pressure ulcers are the same. The non-healing wound, as you can see on the left, where there's increased breakdown of tissue and decreased rebuilding of tissue. And look at the macronutrients. And on the right kind of tells you some different nutritional supports needed for wound healing in the different phases. Our patients all have chronic conditions, and these also affect wound healing. Diabetes, coronary artery disease, peripheral vascular disease, cancer, autoimmune disease, and our patients have several comorbidities that affect healing. Another thing that affects healing is medications. Long-term use of steroids, patients who are on chemotherapy, NSAIDs, or blood thinners. These all have an effect on the healing of the skin. Always remember, when you documenting, to document what you see, but when it comes to trying to create a treatment plan, we need to find out, is the wound contaminated? Is their bioburden? We want a healthy granulation tissue with without undermining, without necrotic tissue. So always address this in the plan of care. Remember our treatment plan for any kind of wound and a pressure ulcer as well. It needs to include an interdisciplinary team where the patient is at the center if possible. The patient needs to take ownership of the wound and needs to buy into the treatment, because it's really going to be difficult to heal wounds if we do everything we can and the patient, when we leave the house, the patient does not do what we tell them to do. So we need to let them know that right up front. You know, ask them, are you interested in this wound healing? And if you are, how much are you willing to put into it? You know, we're going to all do our best. We're going to use the most effective dressings, we're going to instruct them on nutrition. But if they're not interested in healing and they want to eat cake and Coke and chocolate and not wear whatever needs to be worn or not use the pressure relief systems that we set them up with, you know, they really need to be, either the patient or the caregiver needs to buy into the treatment of the wound. The NPUAP, which is the National Pressure Ulcer Advisory Panel, and they're the ones that they're the main voice. And just to let you know that their conference this year is in New Orleans, and it's in March 10th and 11th in New Orleans. So it'll be really interesting. You can go to their website to see what they're going to be talking about, what are the presentations, and hopefully some of us can get there to see at least some of it. Another voice in the wound care world is the Wound Ostomy Incontinence Nurse Society. They offer a lot of continuing education, and you don't have to be a wound care nurse to join the organization. If you go to the www.wocn.org, you can join and have access to the education, and there's different things. Now, their conference is, and this is the society that I belong to, their annual conference is in Salt Lake City, Utah this year in May. I haven't been to a national conference yet, but hopefully maybe this year will be my first. This brings us to the NDNQI, which is the National Database of Nursing Quality Indicators. And this is the group that combines nursing quality indicators with patient experience and nursing engagement survey data, and it helps the nursing leaders to provide adequate care and achieve the highest levels of performance of care. This website is where I want you to go to complete 4 modules so that you get continuing education. The website is here, and it's a pressure ulcer training website. There's 4 areas that you will go through. The first one is about pressure ulcers, kind of a review, but it's some good information. The second one is about different wounds, so it's some of the stuff we already covered and some that we will be covering. Then they talk about the prevalence and incidence of pressure ulcers in the hospital and hospital-acquired versus community-acquired pressure ulcers. Good information. We don't do pressure ulcer prevalence in home health, but it is done in acute care hospitals. I think it's in the major hospitals in this area. They do it. I had the opportunity to do it at UMC. It's a lot of good education. So if you can, when this presentation is over, go to this website, and the main thing is that to get credit, you have to do the 4 modules and the testing all in one sitting. So make sure you have plenty of time. Otherwise, you can go through and just look through the sites without getting the continuing education credits. So if you have any questions, let me know. Now I want to talk about the Braden scale, which is the scale that we use on assessment, and the scale that was created by Nancy Bergstrom and Barbara Braden in 1987. And the purpose of the scale is to help professionals, especially us nurses, to determine a patient's risk of developing a pressure ulcer. And two of the handouts that I want included, and hope you have now with you, are the Braden subscales. It's really important to know what you're doing when you do a Braden risk assessment and to number the numbers right, but also to know that the subscales are very important. And that's what's going to direct your plan of care. The subscales, of 2 or 3 people can have a Braden score of 16 and have different problems. Some could be nutritional, some could be mobility, moisture. So if you go look at the Braden scores and the Braden subscales, which the handout that you have was created by Jennifer Herlo, and it really gives you some good ideas on some interventions based on the score of the subscale. So I'm not going to read the modules. You'll have time to do that on your own. If you want the credit, like I said, you have to make sure that you sign in and go through the 4 modules and get credit for it. But I do want you to feel free to email me or text me any questions that you have. We're going to talk more about measuring and documenting in our last session. We did talk about the pressure ulcers, reverse staging, and from 3s or 4s. 1 to 3, it's always a 3 unless it becomes a 4, but 1 to 4, always a 4, and you don't backstage. Now the OASIS C2, I know that there's different things that we need to know about it right now at this time, but what I'm teaching is from the NPUAP, and the stand that they have is that you don't reverse stage. You can have a healed or resolved stage 3 or 4, but you can't. It was always, the tissue is never at 100% tensile strength. So that brings us to the question of if the patient, if the we get a patient with a stage 3 or 4, but it's healed, and then we get them, they break down because the tissue's not as strong as it was before. We're going to have good documentation. And Heather may be able to address those things about the OASIS C2. Well, thank you for your attention, and always remember to mentor our young nurses and cherish our old nurses. If you have any questions, please feel free to email me, and I'll try to get back with you as soon as I can. Feel free to text me if you have any questions. And to the nurses in Eunice and New Iberia, I plan to be visiting the office with y'all during a case conference within the next 3 weeks. So I hope you have a good day, and Happy New Year to everyone.